Good afternoon, everyone. I'm extremely honored to welcome, on the behalf of the Polish Cultural Institute in New York, Professor Maria Siemionow. Today, we're celebrating the campaign Outstanding Polish Women, organized by the Polish Ministry of Foreign Affairs, and you, Professor, being an outstanding woman and outstanding doctor, are one of the heroines of the campaign, together with some other amazing females. And today, our interview is a special bonus for our audience, as they were given an opportunity to ask you questions. And I have the questions right here in this special bow. And yes, and I think we can start.
Okay, thank you for invitation. And of course, it's always a pleasure to participate in this special event. So, of course, I'm ready for the questions.
I'm very happy to hear it. Okay, so let's go. Let's begin. The first question is, what drives you? What helps you to set your goals?
Well, I think the challenge, the most important part of my career was to challenge myself or being challenged by others. And of course, everyday work is very important, but at some point may be boring. So to be challenged by things which seems to be impossible, but you can evaluate them and then think that at least you can contribute and try is something which definitely drives me for both innovation in science and life, as well as in academic teaching.
And are you working right now on anything, special, like some special project? I know that you've been working on developing a cure for the Duchenne disease.
Yes, so we are continuing the work on special line of cell therapy for Duchenne muscular dystrophy, which is based on the myoblasts, and we are creating a chimera, getting the myoblasts from the father of Duchenne boy and from the boy, and we create father-boy cell, which in this sense is chimera. It's like Greek mythology that you have actually a cell which resembles yourself, so the body will not reject it so easily, but the cell of the father is healthy, is normal. So it is bringing the missing dystrophin, which is responsible for this unfortunate disease for which we do not have yet cure.
I get it. And do you work on it here or in Poland, or maybe in both countries?
So I work in both countries, yes, at the University of Illinois at Chicago. I have my laboratory, and we are continuing all the preclinical studies for many years now, but always there is something which is interesting or challenging to check. And then in Poland, we are working also, we have a lab, and we are working and have collaborators on preparation of this therapy for clinical application.
Okay, great, thank you. It's very interesting. Okay, the next question is, give me a second. What surprised you the most after coming to the United States?
Well, I think coming from Europe for the first time to the United States, there are a couple things. Is the tempo, the actually fast life track, is the way of people are responding. For example, when I sent, even today, an email to the colleague in US, Is it a private person, or is it a collaborator? Is it a scientific research educator? I'm getting response like now. When I send it to Poland, sometimes it's 1 week, maybe 2 weeks. Sometimes I do not get a response at all, unless someone is really waiting for something or asking me just to respond. So that's number one. So it's very important, and that's how the success comes. Because if you are working on the opportunity today, and you want to challenge this opportunity and develop something tomorrow, you cannot wait for the partner to respond in 1 week or 2 weeks. So we are finding another partner and eliminate the partner who is not responding. So the number one is the tempo. Number two is the attitude. I really enjoy the general attitude of people in the United States. It's not like, oh, this is impossible. Oh, we don't know. We will see. We can check, but we are not sure. That's the unfortunate attitude. I'm very Polish and very, very proud. But that's the attitude I'm still seeing today in my young generation of people coming from Poland and today working in Chicago in my lab. That's the attitude. Whereas when you check something with the Americans, they say, "Oh yes, sure, absolutely, tomorrow or maybe yesterday." It's not true that they will, do it, because they may have limitations, and maybe the Polish colleagues have a better options. But the attitude is very important, because the attitude is bringing the atmosphere to the room. If you see and have 10 people who all of them are just looking, well, it's impossible, and you have 10 people who are happy and saying, okay, we can do it, we'll try this and that. So that's very, very important, and that's also how it's moving the science forward. And the third thing is, it's a courtesy in a way. It's trained. It doesn't mean that the Americans are nicer people than Polish people, because I think Polish people have a lot of soul and warmness. However, quite often in daily situations, is it on the corridor of the hospital or in the shopping mall, people are just a little aggressive in Poland. So if you ask about something, so why? Or it's not pleasant, and this is difficult to work and live like that. So 3 things.
I get it. I think the optimism here is very visible immediately, that everything is possible,
I'm not saying it is, but the attitude is changing your minds. And it is well documented in science that when you think positively, you have a lot of endorphins in your brain, which are motivating you to go forward. If you are just responding with kind of a depressive mood, then you will not achieve anything.
Yes, it's hard to work in such environment because you're not driven, to go forward. Sure. Okay, the next question. Give me a second. Is there any outstanding woman in your professional life that inspires you?
Well, I would say today it will be very difficult to compare myself with anybody just currently working. There are colleagues in nerve surgery, like Susan McKinnon. There are colleagues in different countries working in my field. But we are, I would say, at the same level. So they are great, and I think we kind of share the same enthusiasm to what we do. Of course, it may sound trivial, but in the past, in my career in research interest, Of course, I was inspired by Maria Skłodowska-Curie, that's no doubt, many Poles, and specifically women. And I think the fact that she was a great scientist, she was a mother, she was a wife, and actually also a woman who was attractive. That was definitely inspiring.
I get it. Okay, the next question is, it's a long one. What is your opinion of using new technologies in medical domain? Do you think that one day surgeons will be replaced by robots?
Well, this is a question which quite often is asked, and my response is no. I don't think. I think robots are great in terms of supporting surgeons and supporting other medical specialties. It's not only surgeons. You have robots in radiology, correct? You have robots which are performing different analyses. So it's not only surgery. The decision is still human, and even if the decision is given to the robot, and the robot can analyze the decision and advise that, okay, are you considering this or maybe that, because it has more information or a lot of information. I think the human aspect of the medicine and surgery specifically will not ever change.
So still the human will have to make the decision.
Absolutely, to plan more. If we will have more robots, who will construct them? Robots will construct robots? No, humans will construct robots. So if humans will construct robots, the robots are actually a slave of the human. They have to do what the humans have constructed them for and how they designed them. So the robot will do whatever human mind develop for the robot to do. Now, the robot can be learning faster, getting information, just checking Google and finding out, oh, this is okay, this is not okay. But also, I think the human aspect is, would you like to be evaluated by robot or by human when you go to the hospital or you have a problem? Or would you like to talk to robot? Who is the robot? Would you have a full confidence that the robot is not making mistake? Because one of the software was just broken yesterday, and the robot is taking different information from different side and is advising you not to take medication, whereas you should take the medication. So we should not trust robots in 100%, but they are great tool to help us humans to make a better effort and progress in every field in medicine.
I get it, yes. But of course, the human contact is very important when, establishing probably a trust between a patient and a doctor, especially being a surgeon, but mainly in any domain.
Yes, the robot have not operated 100 patients before. He's seeing just this patient for the first time. The surgeon have operated this type of surgery performed 100 or 1,000 times. So the surgeon knows what are potential complications in this particular patient. The robot will do just the procedure, but does not have a memory of 1,000 operations performed and the complications and the good and the bad things which can happen. So I hope it's clear.
Yes, of course.
What is the difference?
Okay, the next question is, that's an interesting one. Can you say that being a surgeon has something to do with being an artist?
In a one way, maybe, yes, depending on the type of surgery you perform, because when it comes to surgery such as face transplantation, of course, you have to see also the aesthetic aspects of the outcome of the surgery. When it comes to the abdominal surgery, so when you remove, let's say, appendix, I'm not sure you have to be an artist, but you can be an artist the way you suture the skin and to be sure that the wound and the scar will not be bad and it looks perfect. So for certain surgical specialties, specifically nowadays, so popular aesthetic surgery, plastic surgery for, beautification and so on, you should be an artist. I think that's given, because otherwise you cannot envision the outcomes of the surgical procedure, which is supposed to, make women more beautiful or younger, looking younger. So that's true. But if you are an orthopedic surgeon or hand surgeon or you are abdominal, surgeon, gastroenterologist, you should be a perfectionist, and you should be, the person very concentrated on what you do. You can be an innovator and bring new procedures. But the aesthetic part in these types of surgical specialties is probably a secondary.
I think we answered the question fully. Okay, the next one is, that's also connected with art to some extent. Sometimes in films, surgeons listen to music during surgery. Have you met with such thing? Do you listen to any music during surgery?
So, of course, I met during my training and my career. There are many surgeons who are listening to the specific music they like. They don't care what type of music it is, just the music. I do not listen to the music. It's for me, it's distracting, and I, of course, appreciate other colleagues' choices. Maybe it helps them. I don't know. For me, music, in a way, does not seem to be appropriate in the operating room, where we are deciding on the lives of people or changing something, performing something important, and automatically it would destroy me. I do not listen to music when I'm writing scientific publications or reading. That's me, but of course I'm not a critic of other colleagues who are doing that. But I think maybe one little criticism is that I think the operating room, the hospital, is for very, very special procedures, and we are privileged as a physicians to work and help people and actually save people's lives. So do it under the rock and roll, maybe not the best idea.
And it's my question. And do you listen to music just for yourself to relax?
Oh yeah, we have the seasonal tickets for symphony. We go to every Tuesday in summer in Chicago. There is a jazz on the Museum of Art gardens. So, and of course I like contemporary music and I like the salsas and of course, and that's I love music, and as I said, we are actually aficionados of music. So, but not in the operating room.
I get it. Okay, the next question is that's a pleasant one. What is your favorite place, both in the US and in Poland?
A place to go or?
Place to go, probably. Yes, place to go to visit.
So in the United States, we are a little bit of nomadic because we have lived in many places in US where I work in different institutions. So Louisville, Kentucky was one of the first places where I trained, and then we live in Salt Lake City, Utah. We love Utah and Salt Lake City. It's beautiful during summer and during winter. You can ski during winter, and you can actually hike and mountain bike during summer. So I think Utah is a great place, and you have the national parks and amazing nature around. I like Chicago because it is a vibrant city. So that's where we live now. From the other places, I would say maybe some of the California Palm Springs, where some of our meetings are. But generally, I think from the places which I could always go and enjoy will be Salt Lake City, Utah, and the surroundings and the parks. In Poland, of course, I'm biased. I'm from Poznan, so I always like to be back. As I used to say, when we travel, now it's limited, of course. We plan soon to go back after 1.5 years almost now. But when I'm in Poznan and I go to the old market, Stary Rynek, I can actually say, okay, I was already in Poznan, I can go back to Chicago. That's what makes me feel good. And I think Poznan is probably my place. Of course, I enjoy being in Warsaw, and I like the vibrant part of Warsaw. But for reasons which I just explained, I'm really very connected to Poznan.
I think people from Poznan are very happy now to hear it. Okay, the next question is, how success is measured in the medical profession? What success means to you?
Well, there are many ways to measure success. I think for general practitioner or someone who is completing medical school, to actually complete medical school and get the residency, it's already success. And depending on the interest, some of the physicians decide to become just practitioners, and they are interested to help other people only, and they are not interested in research or science. So they get their daily success by gratitude of their patients. And I think that's success already when they have a very interesting, good practice. Then for me and for other physicians who are interested also in research and science, to develop innovations for me in surgery, but also in novel therapies like chimeric cell therapy, which is actually my patent, and the innovation which is unique to my laboratory. Nobody else in the world is working on chimeric cells, and we publish about that, and that's a lot of interest. So that's success to publish. I have actually privilege to have 300 publications in PubMed, which is kind of a lot, also in high impact journal factors. But all of these things, and of course to get recognition and get medals, and I publish for books, professional books, and I was editor of the books. That's considered from outside success. For me, the biggest success is to teach other young generation of surgeons, scientists, researchers. I trained over 200 fellows and students and researchers in my lab. About 60 of them are from Poland. And I think the success is to encourage them, inspire them, and what stays in them and how they inspire others based on the fact that I was helping them with their PhD thesis or manuscripts preparation is the real success.
It's great that you have this educational mission and that, share your, passion and, your skills with young people and also people from Poland. You give them the opportunity,
Even today, there are 3 young people who spent a year or more in my lab. They are back in Poland and they are finishing their PhD thesis based on my grants here in the US, and I'm advising them and correcting their PhD thesis in English and in Polish.
That's great. I envy them a bit. The next one is, what do you think is missing in the education of future doctors, both in the USA and in Poland? So I think the question, we stay with the education domain.
Well, maybe that's what I just said a moment ago. I think 2 things. The human touch. Everything is on tempo. It's fast. So it is more and more difficult when you have the tests. You don't meet anymore with professors to have in front exam. Some specialties still you have to take your boards or your higher education exams in person. Most is on the paper. So you are losing this kind of face-to-face meetings. In education, I think what is missing the most is also it's good and bad. So it's good that you have an access to the internet. It's good that you can actually, in a short time, to browse over internet and find specific disease and learn. Whereas years ago, for many of us, it was very difficult because even we did not have access to the publications in English. They were not available in Poland. So that's great. On the other hand, you see your patients are doing the same. They are educated. They browse over the internet. They challenge you when they come. They may read more than you did in the specific disease they are interested about. So this is a new era in the patient-physician interaction, trust. Quite often, because on the internet you can find some good things, but also some bad things. Someone will criticize the therapy you are actually providing or giving for consideration to the patient. So this is something which has to be, in a way, I'm not saying regulated, but it will require time of understanding that the physician is still the one who wants to help the patient to the best of their knowledge, and the patients have to understand that they can be well educated in a very small aspect of what they have just learned on the internet, but they should be also listening. So maybe in the courses of the medical school, it will be important to put more emphasis and also introduce new courses on how the patient-physician relation is changing now due to the access to the internet. And I think one important thing, which is a part of the curriculum in US, I'm not sure because I don't know, so it's not that it's not taking place. But I'm not sure how much of the courses of the empathy are given in Poland. I'm sure there are some, But here I know we have the courses not only for the young doctors and medical students, but for all of us, courses of empathy, how to actually react to the patients. And I think this will be needed more and more, specifically if robots will be will be coming. They do not have empathy, so I don't know how they will react with the patients and how patients will react with the robots. So that's just maybe a new courses on the changing interaction between the medical personnel and the patients on the other side.
I think it's a very good point, because the empathy is, something very important when building this kind of special trust between patient and, doctor. And it's important even for the healing process, because sometimes things happen, a lot in our head, not only in our,
Sure.
body, basically. Yeah.
Sure.
Okay. The next question is, I think it's quite nice. Which situation from the operating room do you remember as the most pleasant one?
Well, probably the most pleasant, or the most pleasant always for me, situation in the operating room, when you perform microsurgery, when you repair or suture the arteries and veins, and when you have to do it using clamps, vascular clamps, and when you remove the clamps, the blood is coming back, and the finger or the face, which before was white and without blood, now becomes pink and is full of life again. So it means that the surgical procedure was a success.
It's amazing that you're so close to life. I mean, seeing it, in so obviously, in a patient in the operating room. Okay, the next one is, I think it's quite a current topic. How much has the pandemic changed your professional life?
Well, I think it changed our lives in general, all of physicians worldwide. In the beginning, we have limited access, and patients have limited access. The new telehealth meetings and visits are still taking place. Some patients are still not feeling comfortable to come to the hospital. So like on Monday, I have 2 telehealth visits. The telehealth visits are difficult because I'm a hand surgeon. So if the patient is telling me that actually has a pain and cannot bend the finger, and I do not have option to touch the hand and to make an X-ray, there is a lot of limitations. But at least in the beginning, I think it's good for the patient to know what are the next steps. And usually now the next step is just to come in person and see the doctor. So that's probably, that was the major change, and slowly it's coming back to normal. And the procedures which were not urgent procedures were just put on the hold for the procedures which, like in orthopedics or hand surgery, the broken hand, of course, the patient was seen immediately and has a surgery if that was required, and put a cast on. But if someone was having the ganglion cyst, which was already for a year, it could wait another couple months, correct? So it's a little different pace of life, but I think we are now coming back to almost normal. It will be never normal, but almost normal.
Yes, to the new normal. Okay, the next question is, how do you prepare for surgery, both in physical and mental sense?
Well, every surgical procedure for me is always a challenge. It's every patient is a lot different, even if this is the same procedure. Then, of course, the body of everybody is different. So you have to evaluate it. Mentally, I always kind of go for, if this is a standard, let's call it standard procedure, like let's say carpal tunnel opening and releasing of the nerve. I just go in my mind through the procedure. I, of course, evaluate the patient chart, and I'm looking if this patient is a special need patient, if patient is diabetic, so that's a different type of patient because there is potential for more complications, or the patient age is important to see how it will work. Then physically, of course, I'm trying to be fit, so I walk. I also go to the gym. Now back to the gym. Before it was only the on the internet you can have classes. Nowadays they're opening gyms, so I'm trying to be fit, to eat healthy, and sleep potentially as many hours as possible, because then the brain gets break and is fresh, and specifically day before surgery, it's important.
Okay, the next one is, does the situation of female surgeons have changed in your lifetime? Is it easier for a woman now to become a renowned surgeon, to make a career?
So it's hard to say, because my kind of a dogma is that I never look upon myself as a woman. Mm-hmm. I look upon myself as a surgeon. So for me, is it a male or a female? It doesn't matter. If someone is good and someone I can trust and I understand that has a good knowledge, it doesn't matter. Of course, the field of surgery have changed because more women are interested to pursue the surgical career. And before, I cannot say if it was more difficult or women were thinking it will be difficult, mm-hmm. or they have different priorities for, childbearing and being the mothers or the family kind of heads running households. It's hard to say, but in my generation, I know at least 5 very successful female from my field. So there are many, many more, but in surgery, a very successful female, which got all the recognitions, medals, and are the mothers and good wives, hopefully, and have fantastic careers. And meaning, being my generation, that this is they have and few, I would say, more senior than me, who have a great career. So I think it really depends on the women choice. If you want to be a surgeon, you love it, you should do it and get it. That's it.
Sky is the limit.
Yes, don't think that because you are a woman you cannot achieve something. That's a wrong perspective.
Exactly. I think especially young women now are, the mindset is completely different. I think they feel they can really do whatever they want. Okay, and the last question is, how do you choose your operating team? Does it happen that sometimes you don't know the people you're going to operate with? So, for example, you've never met them before, and it's just your first time you meet them is just in front of the operating in the operating room.
No, it doesn't work like that. You always know people, and you always choose people. And of course, I have an educational obligation. So our residents, which we know very well, have to have a certain number of procedures. So if the resident is already more advanced in the career of residency, 3rd, 4th year of, let's say, orthopedics, the resident can help me directly, who will be my first assist, or I will teach him and he will be performing part of the procedure, and I will be teaching him and observing him. if the resident is very young in the career, surgical resident, and he will be just a second assistant. So I think this is something which we will look into very carefully. It's never happening that someone is at the operating table who nobody knows.
I get it. I think, sometimes maybe you feel that you just know some people, because of their, achievements, and then you invite them to their operating room, but you've never met them before. But of course, as you say, it's important.
There's a rule who can and who cannot be in the operating room. So, for example, my students or my actually young doctors from Poland, they cannot go to operating room. They can work on them in the lab because they have not a special training. They will need to finish the ECFMG exams to be a part of the surgical team. Or if someone is bringing a new person, this person can be observer, but never be at the patient operating table.
And this is my question: how many people are in your team, that operating team?
Well, are you thinking about the surgery of face transplantation or generally?
Generally.
Yeah, generally.
And then the face one.
Well, the face transplantation, there were 8 surgeons, so that's very unique. But on daily basis, it's usually myself, one resident who is actually a little higher already in his residency education, and then sometimes it's a younger resident or medical student who is working with us on daily basis or rotating with us. And then, of course, is the scrub nurse, and then it's a technician who is kind of running around and giving sutures, and then there is anesthesiologist, of course, on the other side, and anesthesia, assisting nurse. So I would say 1, 2, 3, 4, 5, 6 people, but at the operating table, no more than probably 2 or 3 when there is a small case, or 3 or 4 when there is a bigger case, or 8 when there is, I would say, humongous case such as face transplantation.
Okay, so thank you very much. There are no more questions. The bowl is empty. So I would like to thank you for your time and all your interesting answers, and the fact that you made it, and we had this lovely interview. And I would like to invite our audience to check the social media of the Polish Cultural Institute in New York to check other outstanding Polish women that are part of the campaign. So once again, thank you very much, and all the best for the future.
Thank you for invitation, and of course, good luck to those who will be listening, chatting, and starting their careers in medicine. Thank you.
Thank you.